Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and clinical assistant professor at the Catholic University of America in Washington, D.C. This episode continues our acute care faculty series. Our nationwide collaboration between acute care PNP faculty is dedicated to making sure that pediatric providers are well prepared with the practical skills founded in the scholarly literature that help you translate that knowledge into bedside care for children in acute care settings. This series is especially awesome because the faculty who wrote it are experts in their field, and we were able to breach the boundaries of time and geography to bring you their professional guidance on how to best build your skills. Through collaboration with acute care PNP faculty who span the spectrum of acute care pediatrics, from the emergency department to the intensive care unit, inpatient floor, and subspecialties, we can bring you the best teaching tools from providers who clinically practice the skills every day. The best part of it is that I got to work with my friends who are brilliant and incredible educators. This episode on the approach to the pediatric acute care differential was co-written with me by Drs. Amy Busey and Danny Siebens from Arizona State University. So picture this. It's midnight, and I've just walked out of a shift in the emergency department at Cincinnati Children's to a snowstorm. I'm freezing. A Southerner does not belong in any weather below 32 degrees, and there is a full whiteout. I've promised my husband that I'll be home safely in about 30 minutes, but when I turn the car on, I'm shocked to find that every check engine light comes on, warning me that all the essential protections of my car are dysfunctional. It was totally fine a few hours ago. Does snow do this to cars? Don't ask me. I do not do snow. As I drive home, there's a funny clunking noise, but I keep my hands firmly at 10 and 2, keen to avoid any black ice. Luckily, the blizzard was only starting and I made it home safely. I took the car to the mechanic the next day and felt silly describing the clank, clank, clank noise of the engine. But the mechanic effortlessly said, "Oh, I bet it's your fuel injector." How did he know that after just a few amateur onomatopoeias? Turns out that I had a friendly rodent from the parking lot try to seek refuge from the storm in my engine compartment, who then had a little snack and chewed through the soy wires that wreaked havoc on the engine. The parallels between my parroted car noises leading to the mechanic's determination of my car troubles are very similar to our own diagnostic reasoning in pediatrics. Buckle up as we delve into the art and science of differential diagnosis and diagnostic reasoning. Let's start with a case presentation. You're an acute care PNP working in the PICU and receive a call from a referring facility about a 17-year-old, previously healthy male who presented to the emergency department with complaints of myalgias, headache, nausea, vomiting, and poor oral intake over 5 days. After a brief one-liner about the patient, the referring provider gives you the results of a CBC, CMP, and lipase. The significant findings included leukocytosis with a white blood cell count of 25, bandemia of 8%, transaminitis, and elevated lipase in the 500s. The provider is requesting transfer to the pediatric intensive care unit because of concern for severe pancreatitis and said, "He doesn't look good." Think about the differential diagnosis for this patient based on the presenting symptoms and his age. What are the top few that come to mind? Ingestion, infection, metabolic disorders? You're going to need more information to narrow down the list, but your wheels are turning. Diabetic ketoacidosis, gastroenteritis, influenza, some unknown toxic ingestion. The headache and leukocytosis could be meningitis. That transaminitis is impressive. It could be mononucleosis. Your brain is churning. As you run through the possibilities in your mind, the provider unfolds the case right before your ears. The influenza, COVID-19, and rapid strep test are all negative. Oh, the monospot is -2 and EBV titers are pending. Okay, that knocked out a few diagnoses off your list, so it's time to circle back and consider new differentials. Then you hear a muffled static sound like the hand on the receiver, and the referring provider covers the phone and says, "Is that the repeat lactic acid?" "Yes," you hear in the background from the bedside nurse. The provider proceeds to tell you that the lactic acid is now 12. It was 10 a few hours ago. Okay, well, that's impressive. Are there any other differentials that you need to open up to consider? You now add sepsis higher up on the list because of the climbing lactic acid and significant acidosis. But we still need more information. There's no clear answer yet, so let's obtain a more comprehensive history and physical exam. He hasn't felt great over the last couple of months, but he also hasn't had fevers until now. No blood in the stool, no vomiting. The exam shows some marked hepatosplenomegaly and lymphadenopathy. Did anyone have leukemia on their bingo card for this patient's presentation? A long story short, after days in lactic acidosis and multiple consults across the care spectrum, the patient actually ended up having T-cell lymphoblastic leukemia, and the lactic acidosis was the type B form, sometimes seen in malignancy. This case helps to demonstrate the importance of keeping the differential diagnosis broad and flexible. You know how I feel about keeping your differential open to avoid cognitive bias. Just listen to the Season 7 series on cognitive bias in healthcare. Episodes 49 and 50 can help you avoid common heuristic tricks that can actually lead to systematic errors in thinking. Those systematic errors of thought can impact your judgment in a situation, which can lead to diagnostic error. Just like the case we just discussed, the differential diagnosis list should be narrowed down only once a comprehensive clinical picture is obtained. But what exactly is a differential diagnosis? All acute care PNP students struggle with this concept early in their programs. Let's first start with diagnostic reasoning. That's the component of clinical decision-making that focuses on getting to clinical diagnoses and determining the appropriate medical management. The ability to create a differential diagnosis is a key component of diagnostic reasoning. Diagnostic reasoning defines the differential diagnosis as the ability to differentiate between the possibility of two or more diseases or conditions with similar symptoms or characteristics by systematically comparing and contrasting results of diagnostic activities. Okay, let's break that down. What this really means is that you hone the skill of listening to the patient's problem or group of symptoms and develop a list of possible diagnoses that explain why this problem may be occurring. You've probably heard these constellations of symptoms referred to as illness scripts. Using these scripts, we match mental models of disease presentation to classic symptom patterns in order to arrive at a diagnosis more quickly. They're efficient, but there are dangers lying just under that surface decision. If a presentation does not match an illness script, you need to open up your differential and approach the diagnostic conundrum metacognitively, meaning with slow, deliberate thought. The diagnostic process is complex, and initial decision-making often takes place within minutes of initial evaluation. And since disease exists on a continuum that evolves, and we see a patient at a snapshot in time, a preliminary impression may not represent the final diagnosis, which makes any faulty reasoning that leads to diagnostic error difficult to discern. Information we take in is constantly causing our differential to be in flux, ruling in and ruling out various diagnoses in a differential that can, at times, feel like a whirlwind. But before you get whiplash in this whirlwind, let's look at another example, and then we'll pick it apart. Take cough, for example. A cough is a very common chief complaint, and it's way too vague to help me decipher the underlying etiology for why the cough exists. The list of diagnoses that could be causing the cough seems endless. A differential diagnosis for cough might include anything from viral URI, foreign body aspiration, congestive heart failure, asthma, pertussis, gastroesophageal reflux, acute rhinosinusitis, and environmental allergies. So we need to gather more information for a differential so broad. Let's start with the history. My first piece of advice is to consider the age of the patient. This is an important component of the differential because it informs physiology, pathophysiology, and the epidemiology of the cause. Ask the classic old carts or OPQRST mnemonic. Let's go through them and narrow down our differential. Let's say we have a 7-year-old male who just immigrated from Central America who presents with a cough for 4 to 6 months, not associated with any fever or other URI symptoms. So, going through old carts, the onset, it's chronic. That rules out some acute presentations like sinusitis and foreign body aspiration. Location, obviously in the chest, but we're still thinking about other causes of cough like epigastric pain that could be caused by reflux. Duration, it seems constant, every few minutes. That makes some atopic diagnoses like asthma slightly less likely because they tend to be worse at night. Characteristics, it's a short, staccato cough, non-productive, usually, but sometimes has some frothy sputum, not associated with any URI symptoms. This helps me drive up other diagnoses higher on my list, as I tend to think of frothy sputum in fluid overload. We'll come back to that later. Alleviating and aggravating factors. It's definitely worse with exertion, and he's noticed exercise intolerance. Radiation or relieving factors. He's started to notice some abdominal discomfort. This is going to help us focus our exam. Timing. It's a constant daytime and nighttime cough, impacting activity, and the severity, pretty mild, nagging. So we pair this history with a physical exam, which reveals bilateral crackles and marked hepatomegaly. With this H&P, we can rule out lots of infectious and allergen-induced presentations. Matching the constellations, I'm most worried about heart failure. And now this process has helped me narrow the field of potential diagnoses and supportive studies. Whoa. How did you so quickly get to heart failure? If you're feeling dizzy about this process, let's use the information from our example to build your differential step by step. So, step 1, take a history. Yours is going to be more in-depth than the one in my podcast because you have time to be comprehensive, with a focus on items like family history, social history, and a complete review of systems. Step 2 is to do a focused physical exam. Those both seem pretty easy. How do I get to the comprehensive list of possible diagnoses? It is time for step 3, make the differential list. There are a number of ways to accomplish this, but no matter what way you choose, it should be a structured approach. Some people like problem-based learning, where you rank the differential diagnosis from most likely to the least likely possibility. Or use a mnemonic like SPIT, serious, probable, improbable, and timely. Or a head-to-toe plus hidden systems approach, where you go through each body system head to toe, plus remember those hidden systems like endocrine and metabolic. When you apply those pertinent positives and negatives to the differential development framework, you've likely picked out some key differentials and ruled out some others. Let's practice step 3 with that case that we just talked about, the 7-year-old with cough. You gathered the comprehensive history, and it informed your exam, which had some key findings that help guide us towards considering cardiac etiologies. We'll try 2 different ways to show you a couple of options of forming a differential. First, let's do problem-based learning, where we rank potential diagnoses from most likely to least likely. I'd say it's most likely heart failure due to an unmanaged acquired or congenital heart disease, myopathy, arrhythmia, anemia, hypertension, or kidney disease. How do I know that? Well, I combine the problem of staccato cough without infectious symptoms with findings of hepatomegaly and crackles, and then I took it back to the patho. From there, my knowledge of disease made a cardiac etiology most likely. But let's keep going. It could be tuberculosis, asthma, chronic reflux with aspiration pneumonia, or severe malnutrition. And it's least likely allergic rhinitis or illicit drug use. I like this strategy because it serves the most likely differential, but it still forces you to think about what it could be, even if it's less likely. And that's important for avoidance of cognitive biases, like premature closure. Now let's try the head-to-toe approach. Go down the list, just like a review of systems. HEENT, allergic rhinitis, respiratory, chronic aspiration pneumonia, asthma, cardiac, heart failure due to a number of etiologies, an unrepaired congenital heart defect, acquired heart disease like rheumatic heart disease, cardiomyopathy, chronic arrhythmia like stable SVT, anemia, or chronic primary hypertension. GI, severe reflux, chronic malnutrition. Renal could be kidney disease. Infectious disease could be malaria causing severe anemia or tuberculosis. Endocrine, we're thinking about inborn errors of metabolism causing myocardial disease. Whichever way you choose, I want you to be methodical and keep your differential wide open until you have supportive evidence that you can appropriately narrow it. Okay, now for step 4. You can further narrow your list by ordering diagnostic studies or imaging to support your investigation. In acute care, that list can become expansive and expensive. So be sure you're being a good steward of your resources. It's important to consider the zebras, those rare, unusual diagnoses that masquerade as something more benign. Keep an eye out for those stripes so that you can catch them in the pack of horses. Your multidisciplinary team can be essential in the differential process in acute care. If 2 brains are better than 1, think how great 7 brains are. Don't be afraid to take a diagnostic timeout where you all pause and step back to use a wide-angle lens to reframe the current presentation. Following a structured process in each patient encounter helps to avoid those risky shortcuts. Why is it so important to develop differential diagnosis lists? One of my favorite mentors widely said, if you don't think about it, you'll miss it. And then there's what you've heard me say. Sure, common things are common, but your job is to consider the acute care differential. Even if you do nothing about it, you need to think about it. When a toddler presents with constipation, if we immediately think of only stool withholding during potty training, because we're anchored to the diagnosis without completing a comprehensive H&P with structured differential formulation, we might be tethered to the differential boat, stuck in the water, unable to move beyond our heavy anchor on functional constipation. We'd miss Wilms tumor, placing pressure on the colon that leads to secondary constipation. The systematic approach helps us hoist that anchor and prevents diagnostic errors. We are human, and we know that to err is human. A key aspect of providing quality care is the ability to recognize our biases in real time so that we can course correct, open to the idea of iatrogenesis, the idea that disease may progress during the process of receiving medical care. The National Academies of Science, Engineering, and Medicine tells us that we providers need to give patients an accurate and timely diagnosis. This puts onus on the provider to communicate with families the degree to which your differential is still open, meaning you need to let the family know when you're not certain about the diagnosis given to their child. For instance, it's incredibly common for children to present with fever after a few hours of having a temperature. And when they have no other symptoms, rather than digging for a urine sample or doing blood work, I use the simple diagnosis code R50.9, fever unspecified. because I expect the disease to progress, hopefully to a viral syndrome. But my differential for what it could be is still so open that I can't say any one diagnosis with 100% confidence. And at this point, the use of resources isn't really justified in the well-appearing immunized child who's only had fever for a couple of hours. And this, my friends, is why you hear me harp on objective, quantifiable return criteria. We must communicate with families the degree to which we suspect our initial diagnosis may be incorrect. And each of those return criteria is tied to a differential diagnosis item, complication, or sequelae that could develop later in time. Oh my goodness, finally, all of these mantras are tied together and they make sense. Take it back to the patho. Consider the acute care differential. Give caregivers objective, quantifiable return criteria. I get it. They're all tied to diagnostic reasoning. The ability to develop a thorough differential diagnosis is a differentiating and essential skill of the transition from registered nurse to advanced practice provider. This nurtured skill gives the nurse practitioner the ability to intervene in serious illness, to improve patient outcomes and reduce medical errors. Remain vigilant and embrace the systematic process so that you can mitigate risk of diagnostic error. Don't worry. When you're stumped, take a diagnostic timeout or use those objective, quantifiable return criteria to help you in the face of diagnostic uncertainty. Approach each new patient with a wide-open differential. Leave your biases at the door. Trust your training and remember the acute care differential. I hope that you'll like, comment, and subscribe to the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care PNP faculty who supported the creation and review of this series, and my co-authors in this episode, Drs. Amy Busey and Danny Siebens. You can read about our novel and scholarly approach to peer review our faculty lineup, and learn more about the series, the competency mapping, references, and show notes at thepednp.com. Share it with a colleague, pass it along to your classmates, text it to a friend. There's no financial support or conflict of interest in this episode of the Peds NP. Follow me on Instagram at the Peds NP podcast. Email me at thepednp@gmail.com. And remember, this isn't just a podcast. These mantras of diagnostic reasoning will help you form differentials for the kids. I'm Becky Carson. Take care.